So our today's lecture is on prostate high-dose rate radiotherapy, and our speakers are Doctors Hіларі Беґшов and Shenjin Dai. Dr. Bhaksho is a clinical associate professor and a residency director here at Stanford Radiation Oncology. She specializes in GU and GYN cancers, and she's quite gifted prostate HDR radiation oncologist. She used to be a resident at Stanford and now is a residency director, receiving numerous awards for teaching and mentorship. And Dr. Shenjin Dai is a clinical assistant professor and medical physicist that recently joined us after graduating from a residency at Emory University. Dr. Dai is recipient of DoD Prostate Cancer Research Program Early Investigator Research Award and a PM Research Seed Funding Grant. And so he will speak on treatment planning for prostate HDR, but first we'll start with the clinical presentation by Dr. Bhaksho. Hillary, please take it away. I'll stop sharing.
Okay, thanks, Natalia. Nice to be able to do this today. Let me share. Okay, that looks okay?
Perfect.
Great. So I may just keep an eye on the time and skip a few things, and Cash, I may skip some things so that you can go into it in better detail. So thanks for the introduction, Natalia. I just wanted to thank Dr. Boyanowski, who you guys had a lecture from a month or so ago. He shared me a couple slides just to kind of keep things in sync. So, now I don't know how to do this. Here we go. So this is from his talk as well. As you guys all know, prostate cancer is the most common male cancer in the United States. The median age in about the 70s, and patients live a long time. And so kind of deciding what options are right for the patient is something we really focus on here at Stanford. This is also from Dr. Boyanowski's talk. The risk categorization that we use here depends on, as you all probably know, many different risk factors, including the biopsy grade, stage, nodal status, etc. We also use genomic testing. And in the vein of kind of, making sure that we do the right option for patients, we think often about their, pre-treatment disease state, their urinary bowel function, sexual function, etc. You're probably familiar with this, but just a refresher on NCCN. Most recently, we have essentially 6 categories for risk categorization for prostate cancer patients. And these are just a reminder of how we define them on the NCCN, but as you all are probably aware, also there's different definitions of like more favorable intermediate risk disease, for example, that don't necessarily, aren't necessarily defined here. So today we are talking specifically about HDR brachytherapy. We like this slide here. I think this is also Mark's slide. Just showing the dose distribution between VMAT, this is SBRT, and then proton therapy and brachytherapy. Here we at Stanford only do HDR brachytherapy, although some of this information we'll talk about is, of course, equivalent to LDR brachytherapy. And why do we like this modality? Just allows us to give high dose to the tumor volume, which is the prostate, and low dose to our OARs. This is also from the most recent NCCN, which shows just the dose and fractionations that we use here, including the LDR fractionation for monotherapy or boost, and HDR. I put the arrows, which is what we do here. We do HDR 13.5 times 2 implants for HDR monotherapy, and 15 gray and 1 fraction for boost. And you can see, based on that categorization I showed earlier, what the NCCN, I guess, recommends for using HDR monotherapy or prostate brachytherapy monotherapy. Typically for like low risk or favorable intermediate risk patients, I'd say in practice, sometimes we also provide this for technically unfavorable intermediate risk, occasionally high risk patients only if they, basically refuse other therapies. And then for boost patients, we kind of are in line with the NCCN here. We would only use combination external beam and a brachytherapy boost for patients who are more unfavorable, intermediate, or high risk patients. And we do that very often. So quickly, LDR versus HDR and why we use HDR. Both are good techniques. There's really no randomized comparison. I'd be surprised if there ever was. With LDR, really ultrasound-based planning is used versus HDR. People do it a lot of different ways. Here we do ultrasound-based planning. I'll let Kash go into that in more detail. And the reasons that we like HDR, I'd have to say is, it's a little more slick. We don't have to order seeds or worry about that. We don't have to worry about seed migration, embolization. There's no exposure risk to personnel or family, or minimal exposure risk, I guess. And we can be a little more inclusive of the patients that we would treat with HDR because there's less concern about seminal vesicle involvement or extracapsular disease. We think the radiobiology is favorable and it's been shown to be a little bit more consistent. So for example, this is from a few years ago, it's just showing like the D90 with HDR is much more consistent than that with LDR. This is from a few years ago, but generally speaking, we use monotherapy for low intermediate risk patients, and that the exclusion criteria traditionally have been for LDR, a large gland size, prior TURP, high urinary function score, arch interference, any fistula, or prior radiation. I'd say these are generally relative contraindications, and we have implanted patients, with these features. I'm going to let Kash go into this on the technique, but we do, here we do 1 treatment per insertion, and we do 2 insertions for monotherapy, 1 for a boost therapy. And here again, we use 13.5 times 2 gray, and you can see the equivalent external beam dose listed here. So it's a very nice dose, we think, for monotherapy patients. There is some data looking at, the fractionation. Should we or can we, with HDR, get to a point where we just did like 1 implant, so more convenient, equivalent to LDR in that sense? And actually a few years ago out of Canada, they did a study looking at low and intermediate risk patients. These patients didn't get hormonal therapy, and they, fractionation wise or BED wise, looked at 19 gray in a single fraction versus 27 gray in 2 fractions, based on the radiobiological calculations, thinking that 19 and 1 should be enough dose. And patients, had good toxicity as far as the 19 and 1 fraction. It wasn't more toxic. However, when they showed the PSA response by treatment arm, the 19 and 1 fractions patients didn't have as, quickly a PSA response, but more importantly, their disease control was worse. So the red is the 27 gray and 2 fraction regimen versus the 19 gray and 1 fraction regimen. And you can see that their patients who got 2 fractions had improved relapse-free survival and much better local failure. And this data was presented a couple years ago at ASTRO, so you guys may be familiar with it, but also about the same year, Beaumont did a similar study, not a comparison, but a prospective look at 19 gray and 1 fraction, and essentially showed that with the follow-up, there was higher than expected rates of biochemical failure. And so they said, they don't recommend single fraction treatment. This was their data showing disease-free survival and even for both intermediate and low risk patients, not great outcomes as compared to the 2 fraction. So we still do 2 fraction. We never went to 1 fraction, but unfortunately, at least with that dose and fractionation, it doesn't seem to be a great option. This is from a few years ago, but the American Brachytherapy Society has put out some consensus statements on brachytherapy, specifically prostate, HDR, and LDR, and they in 2012 did a HDR consensus statement. They talk about relative contraindications with HDR, including inflammatory bowel disease, which we're all familiar with for radiation generally, large glands typically thought to be above 60 cc's. Also, I'd say, there's some user interpretation there. High AUA or IPSS urinary function scores. And so those, and then absolute contraindications being fistula, rectal fistula, if they can't get anesthesia or they don't have malignancy, which is pretty straightforward. And then talking about when to use HDR monotherapy. And there has been very robust data for using this for low and intermediate risk patients. Maybe not as much data for high risk patients, but they do, mention it's investigational, but there is some data out there for doing monotherapy for high risk patients. From this publication, talking about the toxicity. So low risk of retention, I find a lot of patients do ask us about this because they're concerned about needing a catheter. I'd say in line with this, we have occasional patients who obstruct after treatment, but this is pretty uncommon. And typically it has something to do with like the anesthesia, or maybe they had they've obstructed in the past, they didn't tell us, and then they obstruct after the treatment. I'll talk about later some of our regimens to try to minimize toxicities for these patients. You can get urinary or strictures, and low risk of any GI toxicity, just because, as it does really minimize the dose to the rectum. And then about 40 to 50%, I would say, do have problems with sexual function after HDR. So I always counsel my patients that ED is a risk still, even if, theoretically it seems that there should be less dose to the, the structures there. It can still be a problem, but most patients do have good luck with medications. And then again, in this consensus statement, they just talk about follow-up, which is pretty straightforward, following patients, every 3 to 6 months for a few years, and then every year with PSA, DRE, and toxicity. I'd say we really don't do, personally, post-COVID and even before, DRE is not something we do necessarily all the time for follow-up patients in clinic, definitely PSA, of course. And then PSA bounce is not uncommon with this modality, just like with other radiation, just like with other radiation techniques for prostate cancer patients. It doesn't seem to portend a worse prognosis. So I always tell my patients, you can see a bounce. It doesn't mean that you're more likely to fail in the end or more likely to be cured in the end. And I just, make sure to counsel them appropriately and keep following their PSA closely, like every 3 months, until we see it downtrend again. And then I always counsel my patients after, any radiation for prostate cancer, but especially HDR, it can take a long time to nadir. So just reminding them of that each time I see them, that we don't expect it to go to 0 right away, for example. Sorry. So we talked about some, I'd say, relative contraindications, but I'd say here in practice, we do implant patients who kind of meet that relative contraindication. So one of them is you want to select patients who have good urinary function going in to the treatment. So typically this is thought of as like an IPSS or AUA score of above like 15, for example. You might not want to offer them brachytherapy. This was a study a few years ago where they looked at patients with high urinary function score or lower urinary tract symptoms, all LUTs. In different stages, only a small percentage of them had a TURP. They were treated with an implant with or without external beam. And after the implant, there was about only 14% who stated they had worse urinary function. The majority of patients actually had better function or no change. So I think that using the AUA or IPSS as kind of a a flag, like somebody has bad symptoms or not, but you can always try to optimize their symptoms either with medication or really go through that scoring, with them to try to understand what's really going on with their urination, and maybe they didn't answer the form right or things like that. The other things I often ask about clinically are like, have you ever obstructed? Have you ever needed catheter? Do you do intermittent catheterization? Things like that, just to make sure that we're not missing something big about their urination that maybe isn't reflected on this questionnaire. The other thing is, I would say most people say that a TURP is thought to be a contraindication to brachytherapy. Here's just some MR images of patients that have had TURPs, and I'd say like TURP defects can be very different. So for example, this one down here is like a huge defect, really hard to kind of identify where there's any residual prostate, versus this one or one that's smaller, like a really small channel TURP. Sometimes that, just widens the urethra a touch and doesn't necessarily have such an effect like this one, for example. So I usually, if they've had a TURP or going to get one, will get an MRI to try to just look anatomically what it looks like, and then make a decision on whether or not I think we could do an implant, because I've definitely seen a wide range of what this looks like. I think with HDR, you have more flexibility than with LDR, of course, as far as where your needles are, where you're getting dosed to, and things like that. And with HDR, it's, of course, more difficult if you've had a TURP or something like that, and lost the capsule. That may be still a contraindication. Gland size is the other often thought of, exclusion criteria. If their gland is like greater than 60 cc's or less than 30 cc's, for example. I'd say in practice here, we do implant patients with smaller glands and bigger glands. So even 10 to 20 cc's we've implanted, and up to, I've probably done, a handful that are relatively large. I think the larger ones are technically very challenging, but this is again, a few years ago, published in Brachytherapy, where they looked at patients implanted with gland size from 20 to 96 cc's. And they also showed no difference in their quality of life outcomes as far as toxicity. Excuse me. So I think if you can do a volume study or something like that and make sure you don't have arch interference, you can implant larger glands, but most of it's about like technically, are you able to get the dose where you want it to, rather than I don't think it's going to necessarily cause them any difference in toxicity. Arch interference is another like contraindication or exclusion criteria that you can see on transrectal ultrasound. You want to just make sure that you can get your needles into the gland. So again, if the gland is way too big, no matter where your positioning is, you may not be able to get needles into the periphery of the gland. And there are some ways that you can adjust the patient positioning with some pelvic tilt or things like that to try to move the arch out of the way. We use a table mounted stepper, so we don't have like that flexibility in moving the template like this, for example. But I know other people that do HDR do it in a slightly different fashion, so they have more like flexibility in getting around the pubic arch. You can check this on CT or MRI, but it's not that reliable since it's not in the treatment position. So here's one of the poll questions. Which of the following is a relative contraindication to brachytherapy? IPSS of 15, a past medical history of COPD, stroke, a gland size of 85 or a medication enlist that includes Plavix. Great. Yeah, so we kind of talked about this. So relative contraindication being a large gland size. Again, I think you can do it, but it's not, you know, it's not very fun if you can't get it done, and a little more stressful. I think the other ones I put in here, you know, this is kind of a middle of the road IPSS, and then I guess the past medical history part just depends, and the medication depends on how you do things. We do these treatments under general anesthesia, so we send them to our anesthesia clinic for a risk assessment first, so that's very helpful. This is just to show, you know, some literature, some updated literature of HDR monotherapy. You can see that people do this in very different fractionation schemes. This is, you know, more fractionated than what we currently do, where we do the 2 fractions. But for example, I just wanted to show this with a pretty long follow-up. This study had like 8-year median follow-up, that the PSA progression-free survival is quite good, 88%, with patients with Gleason 7 disease. So I, you know, typically if I have an intermediate risk patient, tell them that, you know, there's a failure, maybe 15 to 20%. But I think they do quite well. This is from the Red Journal a few years ago, different groups, UCLA, a study out of Japan, and William Beaumont, just highlighting HDR monotherapy for these different risk groups. I just wanted to highlight that. For example, the Japanese group reported on implants for high-risk prostate cancer patients, and they actually have very good progression-free survival. So again, I think that you can consider it for high-risk patients in the right setting. If I do it, I often, make sure they're going to get hormonal therapy, for example. But there are certainly patients who come from a distance that, if they're going to do anything, say that they'll do HDR, and I think it's, you know, it can be a reasonable option. And you can see the outcomes. You know, the UCLA data for the progression-free survival for low intermediate risk is 98% at 10 years, which is excellent, obviously. And then the Beaumont data is similarly quite good. I've just listed some of the toxicities here that they reported. Wanted to talk about HDR boost and when we use this. And this is from the NCCN this year, 2023. So the preferred doses for LDR, HDR are listed here. Again, we use 15 gray in a single fraction for an HDR boost, and typically use this for unfavorable, intermediate, and high-risk patients. Unfavorable intermediate meaning 4+3 or multiple intermediate risk factors, high volume, intermediate risk disease. We often do a boost. And typically here we do external beam either just to the prostate and pelvis, depending on the situation. Typically 46 gray and 23 fractions is what we offer. So some of the data that you're probably familiar with for a boost, one of the most or the newer studies is the Ascend RT, and this has been updated a few times. This was a randomized phase 3 trial looking at intermediate and high-risk prostate cancer patients, and they got 8 months of neoadjuvant hormonal therapy. They got a total of 12 months of hormonal therapy, but 8 months neoadjuvant. They received pelvic radiation, were randomized to an external beam boost to 78 gray or an LDR boost with iodine 125 to 115 gray. You can see that in this cohort, a majority of them were high risk, almost 70%. And a lot of them had high volume disease. Almost half had Gleason 8 to 10 disease. So these are, you know, patients with bad prostate cancer. And I think it's interesting, they got 12 months of hormonal therapy, because often here we do 24 months for high risk patients. but this was one of the updates in 2016, and I just like these graphs, so I have the updated graph next. But this was the proportion free of biochemical progression, and the combination arm was 83% versus 62% for all patients. And then you can see the breakdown by intermediate risk and high risk. So even for intermediate risk patients, there was a large benefit, and same for high risk patients. So high risk patients with a biochemical progression free survival in the 80s is excellent. And this was updated last year with a median follow-up of 10 years. This is all patients. I don't have the breakdown by risk group here, but the all patients proportion without biochemical failure in combination arm was 85% versus 67%, so almost a 20% difference. It was not powered for the secondary endpoints on the update, so overall survival, distant mass-free survival, etc. They didn't see a difference, but again, it wasn't powered to detect that. So I use this data often to talk, especially to younger prostate cancer patients who have unfavorable intermediate or high-risk disease, to try to explain why we're recommending a brachytherapy boost. Certainly for someone who's more elderly or has a lot of medical comorbidities, progression era freedom from biochemical failure may not be a significant endpoint for them, and there's no apparent overall survival difference. But I think for like a 50-year-old who has high-grade disease or unfavorable intermediate risk disease, this is definitely could benefit them. Switching to more favorable intermediate risk patients, and should we use a boost or not? This was RTOG 0232, which was presented at ASTRO a few years ago and then published last year in the JCO. This looked at what I would call favorable intermediate risk patients, but not as defined by the current NCCN favorable intermediate risk, which I think is a little confusing, but they enrolled Gleason 6, PSA 10 to 20, or Gleason 7 with a PSA less than 10, to external beam with an LDR boost or LDR monotherapy. So this is essentially like, can we just do brachytherapy versus combination therapy? And external beam was given to the prostate and the seminal vesicles, not to the lymph nodes in this study. And at 5 years, they showed that the freedom from progression was pretty much equivalent, and that, as you might expect, patients who had combination therapy had slightly higher toxicity, and there was slightly higher late grade 2 or greater toxicity in the combination arm. They updated this and gave a little more information in this by Mahalski, published in the JCO last year, with a median follow-up of 12 years. There was the 5-year failure rate was only upwards of 10% in either arm. So, these patients do really, really well. And over here, they define like the freedom from progression, ASTRO freedom from progression, Phoenix definition, but essentially you can see that it's like in the high 80s for combination therapy and mid-ish 80s for brachytherapy alone. When they broke it down by ISIP grade groups, so more the NCCN favorable intermediate risk kind of definition, they didn't really see a difference either, which is helpful because now we really use this NCCN definition of favorable being 3+4, less than 50% cores, etc. They don't have that granular of data, but I think it's helpful to know that, grade group 2 versus grade group 3, the grade group 2s do a little bit better, but there was again no difference. So I think if you had a low volume grade 3 with a low PSA, it would be reasonable to do monotherapy because it doesn't seem that the combination gives them much of a benefit. Let's see. And they did provide some hormonal therapy data in this study as well. I just didn't include it here. I don't know if any of you were able to go to Astro, hopefully, but one of the sessions, they presented an update on PCS6, which was, and I got some of these from the Astro videos, but this was high-risk patients. Sorry, jumping back to high risk. I put these a little out of order. This was essentially looking at a boost again. So this was high-risk patients who got combination therapy, external beam to the pelvis with a brachytherapy boost versus hypofractionated external beam to the prostate and pelvis. So kind of like the ASCEND trial, but with HDR instead of LDR and with a hypofractionated external beam option instead of standard fractionation. Again, the majority of the patients were Gleason 8 or greater. They got 24 months of hormonal therapy. And they showed that they were just looking at the toxicity, or this was the update, that the acute toxicity was actually pretty minimal, and that the HDR boost patients actually had lower acute GI and GU toxicity, which is interesting because the ASCEND trial, one of the criticisms, or I think why some people don't prefer brachytherapy, is that the patients had on that study higher acute toxicity when they got combination therapy. So the late toxicity and efficacy, wasn't presented, but I got this from the videos. Here's the acute GI toxicity and GU toxicity as intention to treat. And you can see that the brachy combo is the green, lines versus the hypofractionation is the red. So again, brachytherapy seemed to actually provide less toxicity. And that's anecdotally what we've seen in our practice with this regimen, which is 15 gray and 1 fraction boost and 46 and 23 fractions to the pelvis or just to the prostate. And the patients do quite well. So again, this is just reiterating what we do for high-risk patients, which I mentioned. We typically treat the lymph nodes. There was, I think in the ABS guidelines for high-risk prostate cancer patients, they do kind of mention thinking about combination therapy specifically for high-risk patients. There's some interesting data from Amar Kishan from UCLA about high-grade, specifically Gleason 9-10 patients. This is a retrospective study, but he looked at distant metastasis-free survival for combination therapy compared to prostatectomy or external beam therapy alone, and showed that patients, had improved outcomes if they got combination therapy. So we also, if we can do brachytherapy boost for high-risk patients, and this is also one of the things we talk to patients about as to why we recommend that. So here's the next poll question. So this is a true or false question. Brachytherapy boost as compared to external beam alone provides an overall survival benefit for high-risk prostate cancer patients. So I think it doesn't provide the brachytherapy. I guess what I was getting at here is like the brachytherapy boost specifically doesn't provide an overall survival benefit as far as we know. It definitely provides a biochemical progression-free survival benefit. But I don't know of any data that shows a survival benefit for these patients. So again, that's why I think either one is a good option.
You tricked us.
I did trick you. That was my point. Hopefully it sticks. So just talking a little bit about toxicity and some of the management that we do here. So as you might imagine, the acute toxicity is similar to external beam with frequency, urgency, nocturia, risk of obstruction, like I talked about, with risk requiring, potential need for catheterization. I'd say that when that happens, sometimes we'll just put a catheter in. We make them void before they're discharged, and then if they can't, we can put the catheter in, and usually they come back the next day. We take it out and it's no problem. They can have dysuria, hematuria. I usually tell them, it's similar to like their biopsy, for example, and that helps them kind of frame it. And then late GU toxicity, I'd say most patients urgency, like external beam treatment. And then there's a risk of stricture. GI, actually, diarrhea is not often seen with just like the brachytherapy part. Of course, if they get external beam, they'll get some diarrhea, but I'd say more often, surprisingly, patients get constipated just because of the general anesthesia, and they get narcotics sometimes during that. I'd say late toxicity with proctitis is rare, especially with brachytherapy monotherapy. And as we discussed, often patients can retain their erectile function, but I usually tell patients it's about 50-50. For management of the acute side effects, I just put down here what we do. For monotherapy patients, we give them ibuprofen if they can take ibuprofen 3 times a day. We give them Pepcid, and they take Flomax or Tamsulosin twice a day. And sometimes we do different iteration of these drugs if they can't take one of these for some reason. But either ibuprofen, celecoxib, or a steroid to try to just minimize the inflammation, and then Flomax or the like if they can take it. We we give intraoperative antibiotics, but we don't give. We used to give them like 3 or 5 days of ciprofloxacin, but we haven't done that in a few years and haven't seen a significant, increase in infection. So brachytherapy with hormonal therapy is kind of another topic. That's more of a clinical thing that I might skip in the interest of time, so I can give Cash some time. And then salvage brachytherapy, just like one note on this. We do treat a lot of patients who have had prior whole gland treatment with external beam or with LDR, and they have a biopsy proven in-gland only failure. We do provide salvage brachytherapy for these patients. We currently do 24 grain 2 fractions, but there's different regimens that people have published on. I'd say I like this study from Memorial when I'm talking to patients about this, because they broke it down by PSA doubling time prior to the salvage treatment, kind of what the outcomes were or the recurrence-free survival. So if you have a very fast doubling time, less than a year, it's more like 40%, but if it's slower, you might kick the can down the road, longer. So that's kind of how I phrase it to patients. But we do provide this here, and often we'll give them hormonal therapy along with it if we deem necessary, like if they have a higher grade recurrence or something like that. So that's what I have, and thank you so much. I'll let Cash go. Hopefully I have enough time.